It is Healthy Friday, and we look at certain things. There have been stuff that has been swirling around. It's HIV today, it's malaria tomorrow, it's rubella and chicken pox the day after that. It's measles, it's polio, it's cholera. My goodness, it's everything. It's monkeypox. And so today our conversation is around preventative care as well as public health. These are some of the things that we're looking at this morning. And to help us out in this conversation today, going into that is Brown Ashira Olali. He's the Secretary General and CEO of the Kenya Environmental Health and Public Health Practitioners Union.
Most definitely.
Yes, that's a mouthful, but it's a good one because we'll get into it. Preventative medicine and public health in Kenya is what we're going to be looking at today. Brown, good morning.
Good morning to you.
Welcome to the Situation Room.
Thank you.
You're in the hot seat of the Situation Room.
I like this place because this is where situations are shaped and everything is actually done. This is where conversations are actually shaped, and I'm happy to be here today.
Thank you for being here with us today. We're going to get into the nitty-gritty in just a little bit. We're going to give you a little bit of work to do.
Yeah.
Because Dennis is in another country this week.
Okay.
We go to the continent's countries and we bring back their proverbs. And he'll tell you where we are, and we'd love to get your interpretation of that.
Yes, we are in Botswana, part of SADC region, in southern part of the continent, and it is a country that is known for its diamonds. It is a country as well that is known to be having one of the largest populations of elephants. Okay. So even as Kenya tries to ensure that poaching is fought and we get back, remember there are others who are shaping the conversation up there, so we emulate them. But then again, there is also something that we look forward to as Kenyans, and that we talk about democracy. Botswana is known to be one of the best democracies that we have in the continent. A little bit of challenges here and there, but then again, no society lacks challenges. But let's go to the proverb, shall we? A crushed calabash can still be used to draw water. A crushed calabash can still be used to draw water. How would you interpret that?
Well, a crushed calabash can still be used to draw water, meaning that regardless of the situation, that calabash is still very, very important. Really, it is critically important, regardless of how it is. So, regardless of the function, the calabash, the underlying issue is that the calabash is still important to its function, or rather to its what it's supposed to be doing. Yes. Therefore, we need to make sure that at whatever we are doing, we stick to the real issues. The main function of what we actually supposed to be doing.
Yeah.
Yes.
That's interesting. That whatever it is that we're doing, and we can extrapolate that. We can. Okari likes to say we zoom out.
Zoom out.
Exactly.
So when we do that, we realize that there's so many conversations that are happening. But if we don't pay attention to the issues, then perhaps we have an issue.
Correct.
There, right? So when we talk about preventative care, just give us a little bit of an insight, background. What exactly are we talking about?
Preventive medicine or preventative care. First of all, I want to say my name is Brown. The SG for the Public Health Union. For a very long time, we've not had a union that is advocating for the public health officers in this country. And we've been having doctors, we've been having clinical officers, nurses, and others. But now we are there in the space of preventive medicine. And as you have rightfully put, is that essentially preventive medicine is about, or rather public is about, protecting the health of the people before they become sick. We do not need them to be sick, or rather to be treated. We need to make sure that they are healthy. And we draw our definition from the WHO, that's the World Health Organization, or the definition of the word health, which essentially means a state of complete physical, mental, and psychological well-being, and not just merely an absence of a disease or an infirmity. We go beyond diseases. Our work as public health officers, or rather as preventive soldiers, is to decongest hospitals, ensure that Kenyans live better lives, live longer lives. We reduce disease burden. We work to ensure that we mitigate dangerous environmental hazards, and a lot of things that we actually do. So preventive medicine is essentially a branch of medicine that deals with the prevention and really to reduce the disease burden. Yes.
Okay.
Correct.
So we talk about preventative medicine, especially in the country, and let's just again zoom out and then start zooming in slowly, right? So we look at preventative medicine in the country, and one would argue that what we have done for a very long time as a country is to react, not to anticipate and protect.
Correct.
So you look at a time when we'd see preventative medicine was actually taken up critically was during the COVID season, when vaccination exercises were being taken across the country. But you look at our focus as a country right now, even getting jabs for babies is not there, which brings up the question on our stand and our position as a country on preventing diseases before the fact.
Yes.
How are we with that from a practitioner's point of view?
It is a very, very unfortunate situation in this country. I think we've not have had a balance or a scale of balance of probabilities. We've actually overdwelled on curative and forgotten about the very, very important aspect or the component of health, which is preventive healthcare. And it's about priorities. I'll give you an example, and I think I like when we were beginning the show, Ndu mentioned something. He highlighted several diseases, and I think he went as far as talking about measles, polio, cholera, TB, malaria. At this point in time, we should not be talking about emerging, even mpox, emerging diseases. Right now, we are talking about cases actually upsurging up in terms of mpox. But really, it's about priority. We've not really invested heavily in preventive medicine. If I can be able to jog your brain a bit, going by the budget that was actually done last time, you realize even what was given allocated to preventive medicine was very small to public health. It's actually very small. It tells you how we have misplaced priorities. And I think we had a lot of faith, and we still have faith in the current CS for health, because he said when he came in the office that he's actually going to be able to give each and every cadre an opportunity to discharge their mandate fully. And we are expecting to see public health officers coming on the front. What I'm saying is this, is that we cannot be talking about the top 10 diseases. Like the top 10 diseases are preventable, highly preventable. And when we can be able to impress, and you gave a very good example of COVID-19, when simple measures like even washing hands with soap, putting on a mask, a social distancing proved to be very, very effective. And we need to have this discussion go beyond and yonder, and even talk about cancers, non-communicable diseases, diabetes, hypertension, cancers. They're actually claiming lives, and they can actually, those non-communicable can still be cut down if we embrace healthy eating habits, even the diet, even exercise, and all those things. Those are the things that, as a country, for us to make a very important steps, we must be able to balance, and rather provide a balance of between preventive and curative. And that's why even in the Ministry of Health, we have two state departments. We have that for medical services, led by the Honorable P.S. Oluga, and the one led by the State Department of Public Health and Prevention, led by Honorable Mudhoni Muriuki. And therefore, those two state departments are actually very critical in the service delivery of the healthcare in this country. Therefore, what we need to do as a country, I think we need to balance what we do, even the funding aspect, even when we're doing recruitment. Let's make sure that whatsoever we are giving to curative, we are actually empowering the preventive side, so that we can be able to have a wholesome, a holistic approach in terms of health.
Okay.
Yes.
Yes. You say prevention is better than cure.
Correct.
So from where you see it, what are the main obstacles Kenya faces in implementing the preventive health programs?
We have systemic, what I can say systemic problems, ranging from, they are both systemic and structural. Because when I say systemic, we're talking about in HR issues, we're talking about even financing, public health financing. Those are systemic issues. And unless we agree as a country that we really need to empower the public health sector, then we'll be still talking about measles even this time. We'll be talking about polio even right now. So we have those systemic problems. The HR, we have the very weak surveillance systems. I mean, the public health surveillance systems. Surveillance system, we do tracking of diseases as public health. We have disease surveillance coordinators at various points. At the points of entry, we do screening and all those. But you look at even the workforce, the disease surveillance coordinators, actually very few. They retire, we don't replace them. And the workload keeps on going. The population keeps on increasing. And we don't even talk about having these disease surveillance coordinators, having these public health officers being empowered and even being capacity built. So we have systemic problems, we have financial problems, we have, of course, priority. When I talk about priorities, that there's this notion that, preventive is better than cure. But how long do we embrace that notion? We talk about prevention on this other side, then we talk about cure on this other side, but we don't even balance the two. So those are the issues that we're actually talking about.
Do we get it wrong? Because let's look at how what eventually will become universal health coverage has been structured. The Social Health Authority then being the vehicle on which this is going to be delivered.
Yes.
And one of the tiers for a fund is critical care.
Correct.
So by the time you get to critical care, the prevention, you've chucked it out of the window a long time ago.
Correct.
So the preventative care is at the bottom of the totem pole.
Correct.
It's here. But the question would be, shouldn't that be where a lot of the funds go? You should have, if the model that is being chased, that critical care should actually be receiving the least amount of funds, the most funds should go to your tier one.
Exactly.
Should go to your primary healthcare.
Exactly.
Is that not what we're saying?
That's what I'm saying, exactly. And if you look at the levels of healthcare in this country, we have up from level 1 to level 6. But if you look at level 1, where the primary healthcare is the system of Kenya in this country is like we operate like a hub and spoke. The hub is the bigger, the sub-county hospitals, and where if in the event these diseases are not managed here, we can now maybe refer them to the hub. But the spokes need to have the bigger say. And it's at that spoke, or rather that level 1, that we have most of the activities. That's where we interact with the most common. That's where we have problems. We're talking about we're living in a country where we have challenges in terms of even water. We have issues with the pit latrines, toilets. We don't have enough toilets. You go to a county, like, for example, I want to give an example of Turkana or Lamu. We're having still issues with the open defecation. People do not have toilets, and as if we do not bother. That's why we keep seeing a lot of cholera emerging, because there's number one, there's no water. We don't have enough conservancy systems. Those are the toilets, the pit latrines, and what have you. And again, the hygiene standards, if we don't have water, it means that the hygiene standards are actually very low. And we keep a lot of money we invest a lot in buying medical equipment. Like, we saw what happened in Muranga. Muranga did a good job, and I think the governor of Muranga tried to do something about dialysis. But I keep asking them, well, you put up very good machines for dialysis, you put up very nice hospitals, but how many PHOs have we employed, for example? How many public health officers have you employed? How many preventive, how many monies have you put in preventive aspect? And then he'll tell you, maybe I think we have our priorities wrong. So we need to ensure that we balance. And I keep saying at level 1 is where, if something's not done at the level 1, ensure it's not done at all. For example, it's at level 1, at that community level, at that household level that we talk about issues to do with tobacco. For example, we talk about when you smoke tobacco, for example, you can get cancer. For example, if you don't sleep in a mosquito net, you can get, for example, malaria. For example, if you do sex, you don't practice safe sex, you can be able to get STDs or other HIV and AIDS. It is that at that level, because that's the level that you really interact with a common person. But that discussion is not there, because when we wake up, we talk about, we need to go to level 6, we need to empower, put a lot of money in level 6. But we forget that if we can be able to control it at that level 1, we can always have it done. We can reduce diseases from level 1. In fact, going up there, we might not even have much to talk about if we can be able to get it right from level 1.
Brown, you know, as I hear you speak, most of preventative aspect of public health seems as though it's just, first of all, proper communication. I'll give you an example.
Correct.
If you go to some parts of this country, Nyanza, you'd find huge banners, billboards, kikipielka. There is no open defecation in this area. You know what I mean? And as you have this discussion, if you look at now how the counties now would pick up this matter, it's first of all in just having conversations with the locals on the importance of having pit latrines and not defecating in the open, and connecting that to cholera cases that could have been reported in the area. You talk about issues to do with the safe sex. It starts with a conversation. Practice safe sex, use a condom, have one partner, and being committed to a single partner as well. It starts from a conversation point of view. When you talk about dialysis and whatnot, it's about changing your lifestyle and how eating good foods and whatnot would help you. But all we think about is, to which big pharma are we going to get this medication? Which equipment are we getting in? Because we are ready to treat the sick. We are not ready to reduce the number of sick people that come to our facilities. So, which goes to now the community health promoters and whatnot. Perhaps that's the area where we should be investing more in and ensuring that the communities, Kenyans, understand the aspect of preventing themselves from getting sick.
Correct.
Should you be looking that way?
That is true. I want to thank the president. When our president came into power, he had that understanding of preventive medicine. That's why even he went further to provide some stipend to the community health promoters. Community health promoters is not a new idea. I think I need to put it, to contextualize it. It is these people, we have been having them. They used to call community health volunteers. But again, during them times, we didn't actually have a stipend for them. But when the president came in, I think he provided a stipend for these people. A stipend meaning that actually it built their morale to be able to work. And as public health officers, we used to work with them and we supervise them. So where we get it wrong is who is advising the president. If you look at the state council, the state advisors of the president, I've been saying this as a union, we've been saying as practitioners, within the state advisors of the president, we also need to have preventive public health officers who will sit there to advise the president. As much as we're talking about cancer, as much as we're talking about medical equipment, as much as we're talking about drugs, we also need to talk about behavior change, for example, attitude change. Maybe the problem we're having in this country is not even about the diseases. It's maybe about the attitude. It's maybe about behavior. Maybe we've been eating a lot of pizza. Maybe we've been eating a lot of chips, for example. We have not been eating the right food, for example. Maybe we have deviated from what we really need to do. And maybe Kenyans need to just hear that. And maybe we reduce the disease burden. But the people who surround our president and even our CS are really, I want to say, that they appear biased towards curative. And that's why you keep seeing really emerging and re-emerging issues.
Why?
I'll give an example of SHA.
As you give the example,
Yes.
give the rationale behind why it's more lucrative to be in the curative medicine space.
But why should it be what will it gain when you fall sick?
No, but you've just said that folks who are surrounding the president
because it's lucrative,
are leaning towards the curative care. Why?
Is that the only area you can? I don't want to mention. I think you talked about challenges, and that's an area that maybe you get the people who are governing this country. Most of them are coming from that area. I think there's an issue about governance. For example, I want to say that the topmost people who occupy the topmost leadership in the health sector are skewed towards our colleagues who are doctors in that area, and I think that's the area that we get it wrong. We don't appear to have balanced issues. And again, it's lucrative because it also gives people an opportunity maybe to swindle. Remember we had an issue about the KEMSA issue. There was an issue about the KEMSA scandal. The KEMSA scandal came about drugs and all those things being swindled by I don't know who and who. We even have KEMSA billionaires as we speak. So it's lucrative in the sense that it gives people an opportunity to maybe swindle. But if it comes to really issues, then I think preventive should take the center stage of all these discussions. We should, even doctors who are actually at Afya, and I keep telling them, Davji is my friend and all those guys are my friends, they should go to what they are supposed to be doing. Afya is supposed to be like, it's not a ministry of diseases. This is a Ministry of Health. I mean, we need to have a Ministry of Health, not a Ministry of Diseases.
So
if we're having, good oncologists at the Ministry of Health, what are we doing? We're actually doing a disservice to the common people that they need to be serving at various facilities. So we need to, yes.
A lot of attention is shifted to curative
Clinical,
so that
yes.
people can eat.
Yes, it's shifted, and we have been conditioned to think that we need to fall sick. I think we have a problem in this country. The system that we're actually having is a system that has conditioned that, you know what, at the end of the day, you're going to fall sick. So start preparing to pay share in advance or do this, start preparing to die. You know, we should not have such a kind of a system. We need to have a system that invests in making people that, you know, we are going to live tomorrow. Mm-hmm. You know, we are going to fight cancer. We can fight diabetes. We can fight hypertension. But if we have a system that, you know what, pay share in advance so that when you get, for example, chronic and critical illnesses, we are able to pay you in, for example. And by the way, even those guys, the leaders, our leaders, even when they fall sick, they're never admitted in our facilities. Some of them go outside the country, meaning they also don't have confidence in our facilities. And remember, Kenya is the most trained, the best trained brains in the healthcare in this country are actually, and that's why when we have people going outside, our colleagues going outside there, they're actually taken into care of. I wanted to give an example about SHA and say that even if you look at SHA has not even purchased preventive healthcare services. Look at the whole SHA. You look at it, we talk about cancer, we talk about this, but have we purchased about issues about malaria, for example? We talk about malaria. I keep using malaria as an example. Malaria, we talk about malaria control, not treatment. Malaria prevention. Have we purchased services like indoor spraying, for example? Have we purchased services like even establishing food and water quality labs?
How would that look like? Because let's go beyond prescription. Interesting, we're talking about health.
Yes.
But let's go beyond prescription and to actual putting the medicine in your mouth and swallowing, right? So if we say that we're looking at the procurement of preventative healthcare services,
correct,
and you talk about mosquito spraying, how would that work? Do we have agents, officials who have then been resourced at the Ministry of Health and their satellite agencies to go into households and spray? Are we talking about spraying in places whereby they're close to water bodies, funded
yes,
at the ministry level for that to happen? Are we talking about making sure that there are water canisters in different areas so that we start to prevent things like cholera, so that clean hand washing can take place? Have we said that we're putting in public sanitation and ablution areas,
yes,
to ensure that there can be washing away of waste? Is that what we're talking about?
Yes, that's what I'm saying. I'll give you a very good example to answer you. I want to give you a live example of what happened in Mukumu, where we had cases of food poisoning. And we had children, actually, some of them succumbed, some of them had issues. We provided a lab, a food and water quality lab, for example, in Kakamega or in the Western region. Those samples that are actually taken from Mukumu could have actually been, if SHA was purchased that, we could have established a lab, a food and water quality lab, where tests and samples can be taken from there. We take a bacteriological and chemical analysis to analyze whether we have salmonella, whether we have Vibrio there. Then we can be able to, using those results, be able to inform our decision. But look here, we don't have a lab in Western region. We have a lab, and only one lab in National Public Health Lab in Nairobi. So samples are taken from Western to Nairobi, then back. By the time the waiting time, it means that then we are going to actually have our cases actually skyrocketing. So what we are saying, SHA should purchase that some of the services, like the indoor spraying, we have people who are supposed to, because when you're talking about controlling mosquitoes, the endemic areas where mosquitoes actually spread, and we need to have people spraying, and we need to have SHA purchase that. We need to have SHA purchase the matters to do with the food and water quality labs, so that we have labs in each and every, at least if not in each and every county, at least in every region. We need to have ensure that that SHA also purchase matters to do with the wash activities, epidemiology, disease surveillance. When I talk about tracking of diseases, we need to ensure that SHA supports the public health officers or the disease surveillance coordinators to conduct what we are calling contact tracing of people who have been affected and actually crack down on diseases. Otherwise, when we just say, let SHA purchase this, they SHA purchase curative, then we forget about the whole element of preventive. We are likely to get it actually very wrong. And as stakeholders were available, we have been, as practitioners, we have been telling the ministry we are available to provide that advice, even to the president and even to the CS, to do that. We just need to have an open door policy. In fact, if we get inside there, we get things done, I think we can be the best. We can have the best healthcare system in this country.
Now, when it comes to the issue of vaccination,
yes,
recently we had a campaign, and there was an ongoing vaccination on, I think, typhoid
and measles.
But some of the parents rejected the move because of the issue of communication and consultation with stakeholders. What do you make of this?
Vaccination is very important. That's is the cornerstone actually of prevention. Because when you are given a vaccine, for example, all of us, at one point we were actually vaccinated. We revive the antibodies in our body so that they can be able to fight the diseases. But you see, when there's no proper, what you're calling proper sensitization, I mean, there's a gap between the giver and the taker. That's where now we get a situation where we're having disinformation, misinformation. At one point, even the president was actually fighting that when you're actually trying to say, let's vaccinate our animals. And somebody was saying, when you keep vaccinating ng'ombe yangu itakuwa na shida. So such a kind of disinformation and misinformation is actually the one that drives parents to think that vaccination is bad. But vaccination, that is a number one preventive measure. Vaccination, immunization, those are the areas that we actually as a country, we must. And at one point, we didn't have vaccines in this country. But I'm happy because when the ministry came on board and said we can get vaccines, and we actually had it. So it's a question that we need to ensure that we deploy enough public health officers, empower community health promoters to do sensitization, have open barazas, talk to mwananchi. People need to know this vaccine is for what. If it's for typhoid, how effective is that vaccine, for example? The effective dose, the effectiveness of that vaccine. Is it going? It's not going. We need to demystify some myth that when I take a vaccine, some of them are saying I'll be a short person, or I'll have developmental issues or physiological issues. There's nothing like that, really, because vaccination is a scientific process. Before a vaccine is actually released to be used, there are processes that actually it undergoes, and actually will rule out other issues like of those nature. So it's a question of sensitization.
But Brown, you see, even as we talk about a question of sensitization, you find that even whenever this happens, little is being done to ensure that this communication gets out there. You find that the citizenry are left to grapple with all this information at the same time. Because if we talk about measles, or we talk about cholera and whatnot, you find the only focus of this communication is usually around the campaign period.
When somebody gets sick.
Or when someone gets sick. It is not a continued process. Because one would ask you, Nairobi is a beautiful city, capital city, but cholera cases continue to be reported in this city every other day. And one would ask why. The other day I was walking outside a GPO behind that stage. And when you walk there, people are openly defecating in the CBD. You know what I mean? And then look at, so let's even go outside Kenyatta National Hospital. Outside Kenyatta National Hospital, it's now that they've just put an open, a public toilet outside Kenyatta. But previously, you'd find there are people selling foods out there. And when you want to go relieve yourself, where do you go to? These are questions we are asking. So, in terms of having this communication, perhaps it needs to change from a policy perspective, from a government level, push it to the counties and ensure that we not only focus when there is a problem,
Exactly.
that it is a continuous process. Venezuela, even EBC, there is continuous voter registration. Let us have continuous communication on preventative medicine and issues.
I'll put it in two perspectives. One, there's an element of enforcement. And then number two, there's also an element of HR. Because when people retire, for example, you don't expect much to be done. But the enforcement bit carries the largest bit because, for example, the public health officers enforce the Public Health Act Cap 242. The one that now talks about, that even prohibits open defecation. I mean, you cannot be in a position or you open defecate in the open. That is actually, it's illegal. It's not actually, that amounts to pollution. It's not supposed to be the case. But again, it's a question of enforcement because look at it. You've asked a very good question. We have, how many houses do we have in Nairobi? So many houses. You have a lot of gorofas. You go, for example, in Pipeline area, you'll get like one gorofa around 700 people. But looking at the way the pipes are connected, for example, the water pipes, the sewerage pipes. I mean, those pipes move like this. And, you know, assuming there's a leakage, or rather there's a leakage on one pipe or the other, that means there's a whole cholera. Because it's salmonella, vibro, we'll have a lot of contamination. And you might remember, that's the water that we use in Nairobi. Sometimes we don't even boil water. I mean, we don't even treat it sometimes. So, I mean, it's something is more of a structural thing, is more of an enforcement thing. But for us to be able to understand that, then that debate must also be, devolved to that common person. So we need to sensitize our people. Sure. Ask them whatever you are taking, ensure that whatever you are taking is actually good. In fact, even water, don't take water from any source. If a water boozer, for example, comes and supplies you water, for example, in your home, you need to know
where is it coming from?
Where is that water boozer coming from? Has that water boozer been tested, for example? Do they have the KEBS requirement? Do they have the public health requirements to be able to sell that water, for example?
So what we're saying essentially is that preventative care is more about structure.
Exactly.
Across board. It's what are children eating? It's how are we operating even as adults? It's what the construction looks like. And that's just looking at what some of our audience is saying this morning. Edwin is saying, so the infrastructure is a big problem. How it is that we're building settlements. Are we looking at the proper passage of water? Are we looking at, I mean, I'm just going to hazard one, you know, and just because, you know, Aseto is here and I know that he'll allow me to say, just this week, dealing with an issue of lighting in homes and ventilation in homes and how far a building is from the water table.
From the water table is true.
Because we're dealing with things like mold and aspiration, which is then a problem for young children.
True.
These, to me, this preventative care is not necessarily about the needle going in the arm.
Exactly.
But it's about things that's being done at a level whereby you enter into a system whereby preventative care is embedded.
Exactly.
And my mind goes to, I mean, it may sound like something so far off, but it sticks in my head that Michelle Obama, when she was First Lady of the US, she was like, we're seeing a lot of children, you know, sick. Then they're growing up and we're seeing a lot of cancer. And then she thought, you know what, the school feeding program, what are we feeding these children when they're in school? What are we feeding them? So she had a campaign whereby the food, because the public system, everybody's food in the system is the same food. So she had said the food that we give these kids, because she, believe it or not, the US deals with urban poverty as well, and said, you know what, how about we make sure that the food these kids are eating at that level is healthy food? Can we trust the source of the food that goes in? Or are we going to just toss some chicken around because it's kids and we need to do it en masse, in bulk? So she was very deliberate about what that program did to then change the public feeding program at the school level. And you won't see the results today, but likely those kids 8 years ago who are graduating from college in the next 10 years, you will see cases like cancer dropping.
Yes.
But because of what they've done at the preventative level. And is that not the kind of structural intervention that we're talking about? But what is needed for that to happen? What's needed for that to happen? We have school feeding programs in Kenya.
Correct.
We have like we said, Dennis was saying, we have to wait for somebody to get sick. Then we say, oh, hang on a minute, there's cholera. I mean, for goodness sake. What about the structure in place?
I'll say, as public health officers, part of our routine mandates is to continue doing what we are saying: routine inspections, routine interventions, routine continuous routine inspections to ensure that whatsoever we are consuming, whatever Kenyans are consuming, is actually up to standards. But I'll talk of a political goodwill. You know, I'll give an example of Nairobi. Nairobi has a school feeding program being sponsored by a very good program being sponsored by the His Excellency the Governor. But if you look at that program itself, the kind of the people who manage that program, it's actually going to be a problem, because really we do not care where how that program is actually run. If you look at the housing issue in this country, has been an issue. We are busy building houses. We don't care whether those houses have they have the capacity. For example, the capacity. When I'm talking about the capacity, I mean even the conservancy, the drainage system. I'm talking about the ventilation and lighting, because most of the issues that actually happen, we have a whole component called indoor pollution, indoor air pollution.
Yes.
And if, for example, you're in such a place and there's no adequate ventilation of air, I mean, there's through ventilation of air, you realize that you are likely to develop respiratory issues. So do we really, do we have, that's why I began by saying the president really need to have correct advisors. The housing projects are good project, but again, we need to ensure that that project, before that house is occupied, we have something we call certificate of occupation. A certificate of fitness. We have to declare that the house is fit for human occupation before anybody else occupies. We have to balance the politics and the health, because if we just allow, this house has been now complete, now we launch it without really passing, being cleared fit. I mean, we actually also committing. It's going to be a time bomb in the future, because when we have a house that's occupying more than several people, we don't care whether the conservant system is actually in place, the ventilation lighting is actually okay, the water system is okay. We actually putting a lot of burden to the healthcare system, and those are the things that actually we need to be talking about. Let's try and go to the nitty-gritties. For example, even for food to be prepared well, maybe you actually are a food handler. You need to be undergo medical certification. Have a food handler certificate or other medical certificate. For example, you're free from typhoid, for example, so that when you are cooking for us or other cooking for our children, you are not transmitting that typhoid to our children, to our food, because eventually these toxins, we call them toxins, usually, or microorganisms, usually end up in the food chain. So our main area of focus as public health officers is to ensure that we cut, or rather we delink the channel of movement, and that's what we're supposed to be doing. So really, we need to have a lot of political goodwill. We need to have priority areas, for example, in preventive healthcare, and ensure that, for example, we need to do a lot of investments in financing in public health, so that those areas are actually be addressed, and ensure that we reduce the diseases, we reduce the cancers, and we reduce even the cholera, and even if possible, we get rid of polio and all those things. And I'm sure it's possible.
So if, for example, you are handed the docket for health,
yes,
which could be the urgent preventive policy would you take?
Waziri Brown.
Number one, I'll put a lot of more emphasis on prevention. I'll put emphasis on the Public Health Act. You know, the Public Health Act, Cap 242, is one of the greatest acts. In fact, that's the act that even the former president used to control COVID-19. We invoked the provisions of Public Cap 242 to control COVID-19, even to control Mpox, even all those things. So if I was even the minister right now, I'll put more emphasis on the Public Health Act. I'll try and ensure that we give more leverage to prevention than to curative, because really, if we need to have a good and a prosperous nation, you don't talk about a needle. You need to be talking about how to prevent that person to be better, and you need to put in more efforts on prevention, pass laws regarding environmental health laws and sanitation laws, pass laws regarding food and safety laws, pass laws regarding occupational health and safety, because it's those laws that are actually supposed to be protecting the people and protecting the Kenyans at large.
You see, when you're having this discussion, we've pointed out where the problem is and a solution that is there, but one would say perhaps now as a union, one would argue or would insist that you start having this discussion to the powers that be, because you have more access as compared to Kawaida Mwananchi.
Correct.
And one of the easiest thing that one would look at, I still go back to what I experienced outside GPO, because it's crazy, man. You get choked by the smell of urine and looking at feces in the middle of the town. You ask yourself, what are we doing? But then again, if you speak to, say, the street families, if you want to use a public toilet in Nairobi, you have to pay for it.
Correct.
A lot of people are unable to pay that 20 shillings to use that facility. So then how are we having this discussion with policymakers, with these officers, to make it easier to start having these discussions, so that even when you talk about health being handled by the county, that one of the priority areas that they look into is to ensuring that, first of all these public toilets are accessible, they are clean, and that enforcement as well takes place. Because we will talk here, but if you don't take this conversation to them, there is nothing really that they would do.
I agree with you 100%. I'd rather have a toilet that I pay for, regardless of the money, than not to have a toilet at all. Because, like you've rightfully said, if it is what's happening at the CBD, for example, people urinating in the open and maybe defecating in the open, that is a very serious issue. And I think where I sit, I think the county government of Nairobi is doing a lot. We need to do better. I am saying we can do better. We have a lot of goodwill. There's a lot of goodwill from the governor and the rest. I think the system that the governor has put in place, he can do better. So we need to avoid such issues like overcharging people. I think we need to make sanitary facilities accessible and available for use, because really I think we need to also bring it down. Hata kama ni ya kuosha, because I know they always say that money is for maybe cleanliness and maybe to pay some workers there who are actually working in the sanitary, those abolition blocks and what have you. But the underlying issue should be to make the sanitary facilities accessible and available for use by the commoners. Because if the common manager doesn't have maybe the sanitary facilities, that's why he ends up maybe urinating in the open. And therefore, we need to also to health educate. Maybe provide health education to our members of the public and ask them kindly, if you see a sanitary facility, you rather use that instead of actually trying really to destroy our city. I mean, we have a very beautiful city, Nairobi. And I mean, apart from someone was telling us, in East and Central Africa, Nairobi, really, we are proud of having a very nice, very beautiful city. We can't afford to dirtify it with open defecation and open urination. Those are the things that we need to actually tell our colleagues, the Kenyans, to ensure that we at least try to use the toilets and also try to use, once you use the toilet, also wash your hands. And when you greet people and you are actually very clean. Yes.
Hey. Or you fist bump. or you fist bump, which is a more sanitary way of
exactly.
Yes, or you feel exactly.
If we look at what we are in the throes of, what many had described as the next health emergency, with non-communicable diseases, cancer and heart disease being two of those. Cancer, if you look at it, one of the reasons why it was not preventable per se is because of the cost of the preventive care itself.
Correct.
If we look at the two top cancers in Kenya, across it's breast cancer and then cervical cancer, the cancers that affect men are lower on the spectrum than these others.
True.
But that go across board. So number one, breast cancer. Number two, the preventative care is the scanning and the treatment. Pap smear for cervical cancer, mammogram for breast cancer. Before, they were very expensive, and still to some extent they are in terms of screening. When we look at in public hospitals, between 200 and 500 shillings to do the scan, and we can say that that's a little bit of money. But if we look at the truth, it is a lot of money.
That's true.
That somebody would have to look for 500 shillings to then go and get in a government hospital a mammogram.
A mammogram, yes.
In some cases, it is free, but they're not so many. Private hospitals, you look at between 1,000 to 3,000 shillings to be able to get this, just to kind of see what's going on. How does the issue of cost for prevention play in ensuring that we can actually be focusing on preventative care and not towards curative?
And that's why we are saying we have 3 levels of prevention. We have the primary level, the secondary level, and the tertiary level. At the primary level, we try to ensure that we prevent. We don't want people, for example, vaccination that we've said, and things to do with healthy lifestyles and what have you. At the secondary level is when we try to prevent the disease from, for example, cancer, like we've said. Things like screening, for example. It's easier when you detect it earlier and then it's treated as opposed to waiting to go up to whichever level to be now starting getting those expensive treatments. But I'll also want to say that we have Ashira. We have 3 schemes that the social health authority actually does. We have the primary health care fund, we have the social health care fund, the critical and the critical fund that are really supposed to take care of funds. Cancers. But we are actually trying to ensure that we do screening at the secondary level. We ensure that we do screening. If you, for example, you do a screen and then maybe you get by bad luck or whichever way you have cancer, no cancer is good. Whichever breast or whichever can be prostate, no cancer is good. All cancers are cancers. We need to ensure that you get those early. When you're detected early, it can be treated and it can be also actually be taken care of. We have people who are actually surviving with cancer who detected early and are actually living well, good lives. So what I can say is that let's ensure that we do that prevention. We ensure that the costs that we actually be able to, we foresee being incurring at the treatment level, we can minimize those costs by ensuring that we get the screening done early, identify detect the disease, and try to work on the disease to ensure that it does not actually grow or rather multiply.
Brown, one would ask, if we just handled our preventative aspect of medication in this country, just how less of a burden would it be for us to treat these diseases?
The burden of treatment will go deeply down if we handled preventive healthcare. For example, if people were sensitized, if we took this if we invested more in preventive medicine, we had more public health officers, more community health promoters, more people were actually at the primary healthcare level 1, and we are doing actually telling them that, smoking tobacco can lead to lung cancer. Doing this can do this. People get to understand, and people are always attached to a health facility. For example, if I get, a headache, I'll most definitely rush to a healthcare facility. I need to take as a healthcare professional to take advantage of that person and maybe health educate that person on the goodies or rather on the dangers of actually dangerous living, for example, something like that. So if the government invested, if we gave a commensurate, I'm not saying treatment is bad. We'll always have cancers, by the way, because at whichever point they will slip out and they'll be there. We need to have a commensurate budget. Whatever we are budgeting for, whatever is going to clinical, we also must be able to have it at the curative. Remember, we have been overly relying on the donors. And there's this third world order by the US that now they're actually cutting down on health spending and what have you. And that thing, that over-reliance on the donors has actually really also costed us. So if we don't invest more in prevention, we'll also be grappling or rather struggling with the diseases that we can actually be able to actually prevent and protect ourselves. Yes.
Is there a willingness to spend the money that's needed at this point so that you don't have to spend more later?
Yeah, you don't need to spend more. You spend. In fact, if you work on your preventive, you can really reduce on the curative. That should be the math. Work here well. If you want to sleep. Actually, you tell people sleep well, sleep adequately. Yeah. Don't be put in this. I'm over. What are you overworking at the end of the day? If you need to have adequate rest, sleep well, eat nice. Exactly. Don't overeat. Just eat what is supposed to be eaten.
Indeed.
Take a lot of water and do a lot of exercise. And you'll never see the hospital, my brother, because that's why PHOs we exist. We don't want to see people actually falling sick.
You want to see me eat more apples?
Eat more apple.
Exactly.
Definitely, and it's necessary for us to have these conversations. At least put them front and center. They'll be picked up. It's not in vain. We want to thank you so much for joining us this morning. Brown Ashira Olali is the Secretary General and CEO of the Kenya Environmental Health Public Health Practitioners Union. Thank you for being here this morning. Dungo,
Yeah.
you made it. It's 10
I
a.m.
made it. Yeah.
This is the Situation Room, the only way to start your day.